Welcome back. This is Dr. Rockhold again with the last of 3 segments on anxiolytics and sedative hypnotics. In this session, we're going to cover additional drugs used for sleep disorders. We're going to address specific anxiolytic pharmacotherapy, and we're going to recognize the potential that exists in many of these agents for illicit use. I think you're already aware that melatonin is a tryptamine-derived hormone that's released naturally by the pineal gland and which is very much involved in the induction of natural sleep. We recognize 2 G-protein coupled receptors, melatonin 1 and melatonin 2. Melatonin, the natural substance, and the structurally similar agents ramelteon and tasimelteon are agonists at both the MT1 and MT2 receptors. You need to understand that they interact with the melatonin receptors selectively. They have no interaction with the GABA-A chloride channel complex. All of the agents in this class are currently used solely for managing sleep disorders, primarily with individuals who have problems initiating sleep. The sedative effects are mild, and to date, they appear to have little or no abuse liability or dependence potential. They are not regulated by the DEA. Another target for managing sleep disorders is the orexin system. Orexins are a family of small polypeptides that are produced primarily in the lateral hypothalamus. They have those neurons that express the orexins have an extensive connection throughout the brain and are involved in mediating arousal, wakefulness, and appetite. 2 G-protein coupled receptors, orexin 1 and orexin 2, are known. And we have 2 drugs currently available, suvorexant, Belsomra, and lemborexant, Dayvigo. These are drugs that are competitive antagonists at both the OR1 and OR2 receptors. Suvorexant and lemborexant are useful in managing sleep disorders. On sleep lab analysis, they don't seem to alter natural sleep patterns in distinction from the effects produced by sedative hypnotics like the benzodiazepines. We have found excessive sleepiness, hallucinations associated with sleep occasionally with the use of these agents. And when they occur, they seem to occur with a higher frequency in women as opposed to men. Respiratory depression is not a major issue, but in patients who are obese or who have underlying respiratory difficulties, that may be an area for some concern. And then, importantly, unlike the melatonin receptor agonists, these drugs do appear to have some mild abuse liability, and they are controlled by the DEA under Schedule 4. With this slide, we shift gears a little bit. We're going to be talking about specific anxiolytic actions, and we're going to focus on a single drug, buspirone or Buspar. Buspar is a very selective anxiolytic action. It has little or no respiratory depressant actions. It has no anticonvulsant or muscle relaxing actions. At a receptor level, it appears to act primarily as a partial agonist at serotonin 5-HT1A receptors to mediate its anxiolytic actions. How it does this is not particularly well understood, but the current evidence suggests that as a partial agonist, it may end up inducing an adaptive reduction in serotonergic signaling related to mediation of anxiety. One point that is very important to recognize is that the anxiolytic effect is noticeably delayed. It may take 2 to 4 weeks of dosing for that anxiolytic action to become evident. When it's used, it is most frequently indicated for managing generalized anxiety disorder as a second-line drug after introduction of a serotonin reuptake inhibitor. There is little evidence that it has any abuse liability, and buspirone is not regulated by the DEA. Adverse effects are generally mild. They tend to be excitatory in nature, as shown here. Not usually a major concern when the drug is used therapeutically. Again, looking at anxiolysis, if you'll zero in on the algorithm shown in the right side of this slide, you'll see a progression of how you might consider introducing drugs to manage patients who have excessive anxiety. And as you can see, currently, the first line approach is to use antidepressant serotonin reuptake inhibitors. Both the selective serotonin reuptake inhibitors and the serotonin norepinephrine reuptake inhibitors are considered to be first-line agents. Buspirone is a frequent alternative to these agents, and other atypical antidepressants and second-generation antipsychotics or the antihistamine hydroxyzine can also be used in managing therapy. Benzodiazepines are now primarily considered only when trials of these other agents have failed, and this is largely due to the toxicities and the abuse liabilities of the benzodiazepines that we've already introduced. In practice, your choice of an anxiolytic regimen will be influenced by pharmacokinetic and pharmacodynamic attributes of the individual first-line agents and by any comorbid psychiatric issues that your patient may have. The last part of the material will be focusing on an unfortunate aspect of the sedative hypnotic agents, which is their potential for criminal use. Many of the sedative hypnotics have one or more of the properties of reducing conscious inhibitory control, inducing submissive behavior, and or causing short-term anterograde amnesia. Ethanol is certainly a sedative hypnotic with these properties and is often used as a vehicle to deliver additional sedating drugs. Think chloral hydrate in the Mickey Finn. We'll also introduce other agents with similar characteristics, like the benzodiazepine flunitrazepam and the growth hormone releaser gamma hydroxybutyrate, or GHB. Flunitrazepam, which was originally marketed as Rohypnol, is a benzodiazepine with an infamous record of criminal use, including for robbery and sexual battery. In fact, it coined the term roofies. In its original formulation, Rohypnol could be dissolved in beverages and was odorless, colorless, and tasteless. Later formulations were modified to produce a bright blue color or murkiness when dissolved. Of course, that isn't going to help much if the bartender is mixing a little curacao with the martini. Just saying. Rohypnol is no longer produced in the United States, but it can be found in other countries. While Rohypnol is particularly adaptable to illicit use, or at least it was in its original formulation, essentially any benzodiazepine or barbiturate has the potential to be used for such purposes. A second agent that we're going to focus on specifically in this particular context is gamma hydroxybutyrate, or GHB. GHB is a metabolite, a naturally occurring metabolite of GABA, It is believed to act primarily at the GABA B receptor rather than the GABA A receptor. It first gained widespread use in the bodybuilding culture. It's very good at releasing growth hormone and has a tendency to improve conversion of nutrients into muscle tissue. However, in higher doses, it has many of the same troubling characteristics as other sedative hypnotics, although some excitatory effects can be noted when you get into toxic levels. It is currently very illegal. It is a DEA Schedule I agent, indicating absolutely no recognized medical use and a very high potential for abuse. Unfortunately, not only is it very easy to synthesize, but there are a wide number of drugs prodrugs that can be metabolically activated to release gamma hydroxy or to be converted to gamma hydroxybutyrate. The drug as sodium oxybate or Xyrem, which is the sodium salt of GHB, is actually available for clinical use. It is a Schedule III agent and has been found to be useful in the management of narcolepsy. So let's wrap up this discussion of these various drugs. First, you need to recognize the role of the GABA-A chloride channel complex in many of the actions of the sedative hypnotics. In general, these agents are associated with significant adverse CNS depressive actions and have a high liability for abuse, and this has progressively limited their therapeutic uses. Withdrawal from long-term use is strongly associated with unpleasant and even life-threatening effects. Recognize also that the choice of therapies for anxiety disorders has largely shifted away from the sedative hypnotics in favor of the serotonin reuptake inhibitors and buspirone, among others. And then finally, the image at the right here introduces the father of the benzodiazepines, Dr. Leo Sternbach, who first synthesized both Valium and Librium in the early 1960s. Just a touch of history to finish up. I appreciate your attention. Please feel free to contact me if you have any questions about this material. Thanks for your attention again. Bye.